Hello and welcome. I'm Dr. Jillian Horton, a general internist at the University of Manitoba. And today we are going to spend time talking about strategies for finding our meaning and purpose in our medical work. Before we get started, I want to begin with a land acknowledgement. The University of Manitoba is located on Treaty 1 territory, which is the ancestral land of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, as well as the traditional homeland of the Métis First Nation. And when I do a land acknowledgement, this is an opportunity for me to reflect on the relationship between colonization and its long legacy in terms of the clinical problems that I, as an internist, treat every single day, and an opportunity for me to move deeper in my own reflections on the relationships between those two things and reflect as well on what opportunities I can continue to engage with personally with reconciliation. I have no relevant conflicts to declare. So, in terms of my objectives for our time together today, I have 4 of them. So, my first hope is that after this session, you will be able to describe the relationship between meaning in work and burnout. My second objective for this session is that it will give you an opportunity to assess your professional activities and the alignment between both your personal values and your purpose. Thirdly, I hope after this session you will be able to explain the evidence related to crafting 20% of your time to minimize the risk of burnout. And finally, it's my hope that when this session is done, you'll be able to better identify some of your beliefs and the ones that might be limiting your ability to reprioritize activities that best connect to your personal sense of meaning and purpose. I want to invite you to reflect on a couple of simple questions right now. And the first question I want to ask you to think about is, what is your perfect workday? What does that workday look like? What elements does it consistently have? What does that day look like for you? That's reflection number 1. The second question I want to invite you to think about is, what percentage of the components of that perfect workday are actually within your control? So if you look again at that imaginary perfect day, the things that happen on that day, which ones are within your personal locus of control? As you sit with your answers to those 2 reflective questions, I want to invite you to think about 3 specific paradigms for work. And these are paradigms that we do not necessarily delineate with consistency when it comes to our identities as medical professionals. So when we think of our work, we can begin by thinking of work as a job. When we think of work in that perspective, we're thinking about the focus being on a financial outcome, a means to an end, a way to support ourselves and support the things that we need, our material and physical needs in order to live. It's not really a net positive when we conceive of work in this model as a job. The second paradigm that we can use is thinking about our work as a career. And when we consider work as a career, typically that is not a plateau. We think of it as having a trajectory that sees us advancing. We move forward and forward. We become more senior and ascend progressively to roles with more control, more seniority, perhaps more influence. But there's a third model of work that we can reflect on, and that third model is work as a calling. And when we think of work in this way, the focus becomes on whether our work is fulfilling, and particularly whether our work is socially useful and serves a purpose. Now, before you settle on one particular paradigm that reflects your relationship to work, I want to introduce you to the concept, if you're not familiar with it, of medical exceptionalism. Now, historians point out that medical exceptionalism traces back for as far as we can go in the history of medicine And in fact, this quote is from a presentation in the late 1800s, talking to a graduating class, a professor saying to that class that no other profession is essentially as special as medicine is. No other profession demands as much self-negation, as much sacrifice. This kind of language has been part of our professional identity for almost as far back as the records go. And in fact, medical historians point out that medical exceptionalism is the idea that somehow not only is our calling particularly special, and not only are the requirements of that calling physically, emotionally, intellectually, and spiritually particularly special, but it goes along with the idea that there is something incredibly physiologically special about us. And this idea is, of course, just a construct. It's not reality based, but we experience it everywhere in medical culture. And sometimes it seeps into our self concepts, our perceptions of our career, our work, our calling, and can influence us in unintended ways. Now, I want to talk for a moment about some of our traits that are characteristic to us as physicians, and this idea of our job as a calling. There is a body of literature looking at the physician personality, and a couple of interesting papers to point you towards. In 1985, Gabbard published a paper called The Role of Compulsiveness in the Normal Physician. And Gabbard talked about some of the things that are initially adaptive for us, traits that make us thorough, make us detail-oriented, our commitment to patients, our tremendous desire to stay as up-to-date as possible on literature in our field of specialty. But Gabbard also pointed out that those traits can quickly move from adaptive and being helpful to patient care to maladaptive. So diagnostic rigor can also lead to, for example, difficulty letting go. Being thorough can mean that we have trouble setting appropriate limits or giving ourselves the ability to stop thinking about cases or mistakes that we've made. Our commitment to patients can lead to an exaggerated sense of responsibility. And our desire to stay up to date can actually become maladaptive when it is riddled with anxiety, a sense that we are always behind, which actually is reflective of the reality of the volume of information that we are assaulted with every single day in our medical specialties. Lemaire and colleagues have also looked at aspects of the physician personality and how we identify with certain characteristics, such as describing ourselves as workaholics or being control freaks or type A plus, as I have heard it described elsewhere. And when you look at Lemaire's construct, you can see that many of us identify with one of these descriptors. Many of us identify with two, and a large cohort of physicians identify with actually all three characteristics as being central to their personalities. There's a concept that I think is very helpful in the physician wellness literature, and that concept is known as self-valuation. Now, I often think of self-valuation as being a reflection of how willingly we will put other people's needs first on a consistent basis, even when perhaps it is not absolutely necessary for us to do so. And some of these things, I think, for many of us can become habitual, things that we just do without actually thinking on a day-to-day basis. So some of the questions that we can answer that can give us insight into our own score when it comes to self-valuation are things like, when I make mistakes, I experience more self-condemnation than encouragement, or I am less compassionate with myself than with others, or taking care of my own needs seems incompatible with taking care of the needs of my patients. And we know that the lower our self-valuation scores, the higher our risk of burnout. And indeed, I do believe that when we experience the sequelae of chronically low self-valuation, one of the things that happens is our sense of meaning and purpose and satisfaction in our work can also become threatened after a long period of time living this way. Now, there's definitely evidence that doctors struggle to integrate our professional and personal lives. And one of the things that this results in is a feeling of deep and private conflict about the relationship between our work, our job, our career, or our calling, and our relationship to the work that we undertake with a sense of great purpose for the most part and high aspirations. Dr. Tate Shanafelt, who is one of the leading experts in the world on physician health, well-being, and burnout, talks about in one of his early papers that some of the characteristics that are common among us as physicians are a survival attitude, especially during residency. We have a sense that we'll just do whatever it takes to get through the experience. Also, delayed gratification. We enter into medicine with a sense that we're following a blueprint that is laid out before us. And at the end of a great deal of challenge and suffering, we will experience a particular outcome. So we are people who are very good at delaying gratification. And finally, we equate well-being with escape. We think of well-being as something that we'll achieve on a vacation or that we have to leave our clinical environments for. And this, of course, is not reality-based and does not help us to achieve fulfillment at work. Even though vacations and rest are important, this is not a strategy for organizations or individuals to achieve well-being in their work environments, to think of escape as the only thing that they can do. So I want to invite you to think for yourself and to notice what arises for you when you personally reflect on the question of whether your work is a job, a career, or a calling. So you may have a private answer to that question that you would not necessarily be comfortable sharing with other people. And if you notice that that's the case, I want to invite you to ask yourself the question, can more than one thing be true at once? So it may be for all of us that some days at work, some of what we're doing just feels like a job. It just feels like a means to an end. And other days, what we're doing feels concordant with that sense of calling. And then there are other aspects of what we do that, again, mirror that career paradigm. So introducing the idea that more than one thing can be true for all of us. We don't have to ascribe to one paradigm. There may be elements of each paradigm of our relationship to work that feel true. That's normal and quite common for us to sense that the answer to that question might be a little bit dynamic. I want to shift now to talking for a few minutes about meaning and purpose in our work as being a key ingredient to our professional fulfillment. The Stanford WellMD professional fulfillment model is a wonderful framework for us to internalize. It's my belief that it helps us begin to conceive of not only our own well-being and professional fulfillment, but how we can begin to move forward in our roles as leaders, as physicians who are part of professional groups and clinic groups and a number of individual cohorts, to think about how we can improve professional fulfillment on a number of fronts. But the Stanford WellMD professional fulfillment model tells us that in order to experience professional fulfillment, we need three things. So the first thing we need is a culture of wellness. And a culture of wellness includes leadership that is responsive to our needs, leadership that is emotionally intelligent. It also includes equity, diversity, inclusion, and a sense of belonging, a sense of esprit de corps with the people that we work with. Flexibility in our work hours and our work arrangements that reflects the complexity of our personal lives, now more so than ever. The second thing that we need in order to experience professional fulfillment is efficiency of practice. So how much time in our work is wasted repeating tasks that would be better done by other people, searching for beds, working across multiple electronic medical record platforms, doing the same task over and over that really does not affect the quality of patient care or relate directly to our expertise caring for patients? How much cognitive load do we carry that could be mitigated through external organizational measures? It's very hard for us to experience professional fulfillment if efficiency of practice is very low in our practice environments. And the third thing that we require for professional fulfillment is personal resilience. And personal resilience is about 10 to 20% of the overall factors related to how professionally fulfilled we are. And when we look at the problem of physician burnout, again, we know that it's not an issue with you not being resilient enough or me being not resilient enough. That, again, is only 10 to 20% of the overall problem. The primary drivers are organizational, cultural, efficiency of practice, processes related to our organizations. But personal resilience is the piece that relates to our own physical fitness, our own cognitive fitness, our own sense of the social fabric that we have supporting us outside of medicine, the robustness of those social networks, how well we tend to our physical health, our sleep, our diets, our exercise, when we have the opportunity to exert influence over those things. But the point I really want to make here is that in order to experience professional fulfillment, we need all of those three things. We can't just have one. If one domain is really poor in our life, then it's like a loaf of bread. We're missing an ingredient, and we will struggle to experience professional fulfillment in our lives. Another concept I want to introduce you to along those same lines is what's sometimes called the Shanafelt honeycomb matrix model. So this is the idea of looking at burnout versus engagement. And in Shanafelt's model, we see that meaning in work is supported by a number of other drivers. Our sense of work-life integration, our ability to exert control and flexibility, our workload, our job demands, efficiency in terms of resources and resource allocation, the values of our organization and whether they're aligned with us, and what kind of community we have both outside of work and inside. And we can see that when these drivers are not supporting our sense of meaning in work, that we're more likely to move towards the left side of the model, to experience exhaustion, cynicism, and a sense of being inefficient and inefficiency at work. Versus when everything is in alignment and those drivers are supporting and helping us to develop our sense of meaning at work, that we experience engagement and vigor, dedication, and we feel absorbed in the work that we are doing. Now, finding our work meaningful actually affords us a kind of psychological PPE. One of my favorite books on resilience is by the psychiatrists Southwick and Charney. And one of the things that they emphasize in their book, Resilience, which is highly worth a read if you're looking to learn more about the subject, is that having a sense of clear purpose dramatically strengthens our resilience. So this is one thing that we can continue to do on our own. One thing that is within the locus of control that we do have. We can continue to try to make our sense of connection to our meaning and purpose as strong and as clear to us as possible. Now, an interesting and widely cited study done in 2009 by Shanafelt and colleagues looked at, in an academic setting, what work clinicians were likely to say that they found the most personally meaningful. And when you look at a summary of the responses, the majority of respondents said clinical care was the work that they found the most meaningful. A smaller percentage identified research, education, and then the smallest percentage as administrative work, or an even smaller percentage identified other work as being their most personally meaningful. So this leads us to an interesting question. And that question is more better? Are you actually better positioned if you find a higher percentage of your work meaningful compared to a colleague who does not have such a high percentage of meaningful work when they look at what they do in a given week of their clinical lives? And the answer might surprise you. It originally surprised me. The answer is that there seems to be a magic number after which there is not much benefit to you finding yourself doing your most meaningful work. And that number is 20%. So to put that another way, after 20%, there does not seem to be any additional benefit when it comes to the relationship between doing your most meaningful work and decreasing your risk of burnout. So here's the next question. Is less worse? So there are some factors that are independently associated with a greater risk of burnout. And this also comes from Shanafelt's 2009 study. So the first factor is poor career fit. If you are devoting less than 20% of your effort to the activity that you find the most meaningful, and again, this applies to academic clinicians, but we can probably feel safe generally extrapolating this number, then you are at an increased risk of burnout. You have what Schoenfeld and West describe as a poor career fit. The second risk factor independently associated with a greater risk of burnout in this study was an age under 55. And most of us can say this actually makes sense because this is probably when we are doing some of the heaviest lifting for those of us with families when it comes to young families, childcare responsibilities, and struggling to balance all those other aspects of our lives. Or perhaps we just learn skills as we age that make it easier for us to deal with stresses associated with burnout. And also, as we acquire more seniority, we mostly also acquire a bit more choice over what we can do. Thirdly, hours worked. Total hours worked. The more hours you work, and in particular in other sources of literature, working more than 60 hours a week is associated with an increased risk of burnout. But total hours worked is a risk factor. And finally, from this work, being a generalist is a risk factor associated with a greater risk of burnout. To me personally, as a general internist, this makes sense. There is an almost unlimited sense of the things that I feel that I need to keep up with in order to practice as a general internist in an academic center. So intuitively for me, that resonates with me as something that feels true. So what is the low-hanging fruit here? Well, the message that I really take away and actually find incredibly comforting from this study is that physicians who spend at least 20% of their time in the aspect of work that they find the most personally meaningful had a burnout rate that was roughly half of that than the people who spent less than 20% of their overall effort in the work that they found the most meaningful. So I want to shift now to the question of how we get to that 20%. And I do want to say that even though those of us who are practicing physicians do have most likely some increased ability to influence our choices and what our work looks like. We do have more capacity probably for negotiating those things and exerting choice. I do want to say that I think there are lessons here that apply even to residents as they begin to look at what their most meaningful work is and how they can choose to prioritize the things that they find the most meaningful, even in the course of their very busy work days. So here I want to invite you to take a moment to think about your typical work week. And so if you have more than one type of work week, as many of us do, a week on a consult service, then a week on an inpatient service, then a week covering outpatients, maybe you travel to a different location altogether to provide service, you want to think about each of those types of weeks or settings that you work in separately and ask yourself the same question about each of them. So what I want to invite you to do, and if you'd like to do this now, you can just hit pause while you do it. Take a pen and paper and see if you can create a pie chart for each one of your work types or work weeks or work environments that's similar to this type of visual model and that allows you to look and see what your work distribution looks like. And what you might end up doing is creating new categories for each of the types of work that aligns with your own job. And so you create a personalized pie chart. So, for example, if you are a person who does a number of procedures in one particular role or work type or work week that you do, you might find yourself describing or breaking down those types of procedures within the pie chart that you create that represents your work. So just taking a moment now to create the pie chart that represents the types of work that you do and thinking now about the percentage of time that you spend doing all of that work. Now, if you like, I want to invite you to ask yourself the question, looking at your different types of work weeks within the different settings in which you work. I want to invite you to ask yourself which activities are the most meaningful and which activities are the least meaningful. So from the different categories that you created on each pie graph, ranking them from most meaningful to least meaningful, and doing that for each one of the pie graphs that you've created. Now, here's the helpful question. I want to invite you to consider that percentage of time as it relates to meaning. So when you look at all your work settings, what percentage of your time are you spending on the work that you find the most personally meaningful? And what percentage are you spending on the time that you find the least meaningful? Now, I want to invite you to consider the percentage of time as it relates to meaning. So, what percentage of your overall time, looking at all of those pie graphs, those work settings together, what percentage of your overall time are you spending doing the work that you find the most meaningful? And then when you look at those pie graphs again, what percentage of time are you spending doing the work that you find the least meaningful? So now that you are looking at this worksheet that you created in front of you, you're probably wondering, well, what on earth do I do with this data? And that's what we're going to talk about. There is a concept in the world of organizational and behavioral psychology called job crafting. So, job crafting embodies a few key concepts. And one is the idea that we can take proactive steps that allow us to redesign what we do, essentially changing both our tasks and our relationship to those tasks and our perceptions of our jobs as a result. And another component of job crafting is it gives us the sense that instead of our jobs being inflexible and things that we simply have to conform to, reframing our jobs as being tasks and interpersonal relationships that are independent building blocks, that are flexible, that can be rearranged, reorganized, restructured, and reframed so that we can construct a customized job. And maybe that's the point for all of us where our job moves from being a job to a calling and ideally allows us to have more of a sense of meaning and purpose. So, one concept that's embedded in job crafting is the idea of task perception. And this concept was really nicely illustrated to me once by Dr. Chris Simsky, who is the Vice President of Professional Satisfaction at the American Medical Association. Dr. Sinsky talked about the fact that one day she was on her way to see her umpteenth consult in the emergency department. She was tired. She'd had an incredibly busy day. And instead of thinking to herself, oh, I'm going to the emergency department to do another consult, she consciously decided and said to herself quietly, I'm going to the emergency department to help a patient. I'm going to have a meaningful encounter with a person who is never going to forget me. That's what is encompassed when we engage with task perception. So we try to reframe. For example, is the person laying bricks? Are they simply laying bricks and doing menial labor? Or are they building a bridge that will be used by generations? So when you plow snow, the person who's plowing snow, I live in Winnipeg, so that's a frequent occurrence. Is that person simply plowing snow, doing menial labor? Or are they clearing a path so that an ambulance can get a sick child to the hospital and save their life? And on a more granular level related to our work, are you seeing a consult? Are you doing what Dr. Sinsky was, simply seeing a patient? Or are you alleviating human suffering? Are you being given the opportunity to forge a deep and lasting connection with a person, no matter how fleeting, something that will impact them forever? So, task perception is something that can be very helpful to us when it comes to the concept of job crafting. We can also begin to think about the concept of tailoring our relationship circles. So, this invites us to ask the question, can we change the ratio of whom we interact with and how we interact with them in a way that best aligns with our meaning and purpose? So, we might find that we get incredible satisfaction providing team based care, working closely with our colleagues in allied health. We might have other colleagues who do not experience that same satisfaction and prefer to work a little bit more in isolation, caring directly for patients without the support of any other team members. We can all begin to identify those individual characteristics, and we can actually, with some effort, tailor our relationship circles accordingly in certain environments. We might also find that we are people who really enjoy long conversations with patients, and other people are a bit less communicative and do not enjoy or are not as skilled in that realm. And so we may find that for those individuals, outsourcing some of that communication, getting the support of someone who is a very strong communicator in allied health, or having colleagues take some of the more relational tasks related to our work, colleagues who find that is where they derive their meaning and purpose. This is an example in our work environments of how we can actually tailor our relationship circles so we are all more likely to be able to spend more time doing the work that we find the most meaningful and purposeful. Now, I want to invite you to ask yourself a question. And that question is, what feels challenging to you when you reflect on this concept of job crafting and the idea of getting to that 20%? So, some questions we can ask ourselves. Are there any assumptions we make about our ability to get to 20 that might not be true? Have we decided already that somebody will say no to a request we might have in our work environment, or a colleague might not want to change the way that they distribute work? Might our assumptions be false? Are there other barriers? Are there uncomfortable truths, i.e., fixed beliefs about things that we must do, an income that we must make, independent of our actual financial needs and our family circumstances, but the idea that somehow we're a failure if we don't make as much money as other people, even if it allows us to do more meaningful work? And are there personality influences or personal influences, family members or mentors or colleagues whose opinions we value, that we sometimes make choices based on the influence of those things without really taking into consideration that it's other people's perception of our work that's influencing our choices? So sometimes those challenges, we really have to be willing to look at what our own beliefs, biases, perceptions, and things that we've decided will not be possible for us. Sometimes we can challenge what those assumptions are and look at, in fact, our limiting beliefs. So, here in my experience are some common limiting beliefs that prevent people, especially in the early stages of their careers, from getting to that 20% of the work that they personally find the most meaningful. So the first thing is they think it won't matter. It won't help. My job is so hard. I'm already leaning towards burnout, experiencing burnout. Getting to 20% won't help me. And the reason I call that a limiting belief is we don't know that that's true until we've tried. There is evidence to suggest that this formula gives us some immunity against burnout. So challenging yourself, asking, is the reason I think that this won't matter because I'm experiencing the cynicism that is often one of the cardinal symptoms of burnout? The second limiting belief is people often think to themselves, well, the things that I find the most meaningful are not well compensated, and therefore this isn't going to be possible. I can tell you from my own career journey that early on in my professional life, things that gave me a lot of meaning were not compensated at all. But I began laying the groundwork for developing expertise doing them. A wise colleague of mine, Dr. Ron Epstein, once told me that when we want to do non-traditional work, sometimes at the beginning of our career, we have to give it away. We have to essentially do proof of concept work to show that the things that we want to do are viable, that there is an interest in them, that we do have the skill to do them. So sometimes it's true that that work is not compensated at the beginning of our career. However, when we are strategic with good mentorship and a long game, we actually can create pathways where that work is not only minimally compensated, but well compensated. And the third thing people say, well, my boss won't take this seriously. Nobody cares what I think. I can go and ask for this and nobody's going to be interested. I obviously don't know your boss, but I can tell you that emotionally intelligent leaders, especially when we can present evidence, when we can go to them and say, you know what, here's this literature that shows that I should be doing 20% of my work doing what I find the most meaningful in order to reduce my risk of burnout by half. I'm not doing that right now. Here's the way I could get up to 20. My experience is that when we arm ourselves with literature, in particular, because we speak in evidence as physicians with environments that are progressive, bosses that are emotionally intelligent and understand the crisis of burnout that we face, people may listen. So not assuming from a place of cynicism that people will disregard this when we go with a plan that is strategic and we've thought out our case. And finally, a limiting belief is often we say, my peers don't share my values. No one cares about patient-centered care the way I do, or spending time with families the way I do. Now, in your work environment, that may absolutely be true. But again, sometimes we tend to make assumptions and overstate the degree to which we are different from other people. And if this limiting belief is true, then that can sometimes be an indicator for us that we are in an environment where we are actually poorly matched. And if you think back to that model I showed you earlier, the professional fulfillment model and the culture of wellness, this traces to esprit de corps. And if we have a sense that our peers do not share our values, that we don't belong where we are, then often that's actually a sign for us that perhaps what we have to look at is whether we need to move to a different environment. And sometimes that is the outcome of this type of work, this type of exercise. We realize actually, I've done everything I can. I am not a fit, and I need to go and find my environment and my people. Now, you might think this all feels futile. And I know what that's like. I've been there too. I have experienced years of extreme professional burnout, and I've worked hard to job craft and get myself to a different situation that eventually did have a significant impact on my burnout and my sense of meaning and purpose in my work. But what I really want to emphasize to you is you don't necessarily need to know exactly what you have to do today. But as my friend and colleague Ron Epstein says, it's critical that we do something. We don't need to understand exactly what we have to do to have the perfect solution before we try to begin to address the problem. Trying one thing, then trying another, altering based on your early reflections on what work gives you the most meaning and purpose. This is at least a way to begin, a way to restore for all of us some kind of sense of a locus of control in our work. So we can't wait for a perfect understanding or knowing exactly what we must do, but we have to do something. And that's what I'd really invite you to think about in terms of the content that we've talked about so far. What can you do? What is an early first step that you can take that may be helpful? So finally, before we bring this session to a close, if you still have that pen and paper, I want to invite you to consider whether you would like to do a commitment exercise. And so when we think about the subjects that we've covered today, the first thing you can ask yourself is, what is one thing, based on what I've heard today, what is one thing that I will either attempt or consider or reflect on, or that I might even attempt to change based on what I've learned today? And the next question is, what steps will you take? What specific steps? They can be incredibly small, but they should be, as we all know, with SMART goals, they should be very detailed and they should be actionable and things that you're actually capable of doing. And then the next question is, how will you remind yourself? Can you put a prompt in your online calendar right now to remind you 30 days from now? A reminder pops up that says, remember your commitment exercise. What steps have you taken, those steps that you committed to? And so finally, with those questions in mind, writing down for yourself what it is that you commit to at the end of the session when it comes to taking steps based on what you've heard to try to find meaning and purpose in your work. And with that, I want to thank you so much for your time today. I hope you found this session useful, and I want to wish you luck in the lifelong quest that we all face when it comes to finding meaning, purpose, joy, and work-life integration in the practice of medicine. I do believe it's possible. Thank you.